My name's Dyfrig Ap Dafydd. I'm a GP in Llangefni and Anglesey. I've been a cluster lead from Anglesey, and I'm also one of the primary care leads for the planned care programme. One of our main projects is the Community Health Pathway Project. This is a collection of pathways based on best evidence, agreed nationally and then localised so that you know what your local resources are, what's available to you, and who we should be managing and how. And this year we're supporting the quality improvement projects because they overlap with the Community Health Pathways programme, where the same team has been involved in writing this QI, has also been involved in updating the guidance for managing kidney disease. One of the biggest and most important issues this year is looking at flows in use. We know, a bit like statin reduces cardiovascular risk by 25%, and ACEs reduce your cardiovascular risk by 25%, Flozins will reduce your cardiovascular risk by 25% or thereabouts, regardless of what it's doing for your HbA1c and diabetes. And so the licensing has been widened to use it for conditions outside of diabetes. We've also seen significant reductions in end-stage renal failure, and the renal network is particularly keen to make sure that we're aware of the huge benefits Flozins are for this population and keen to implement their wider use. Now, I think it's fair to say that over the past few years since QOF went, there has been a slight loss of monitoring of CKD. If you're EMIS, the searches simply disappeared when it's deactivated and you don't have any prompts for CKD, in much the same way that we don't have any more than 3 of the 8 processes in our QOF register searches, and don't have any prompts for diabetes for the 5 processes that we don't have a search for. But when we consider the potential benefits of the whole statin, ACE and Flozin group medications in these very high-risk patients, and the fact that they all reduce cardiovascular events by really significant amounts in a population that's already at risk, and we recognise that we're not perhaps targeting and managing these patients as aggressively as possible, then I think we can all see that it's a worthwhile project, and I think we should be quite enthusiastic about this one. And as well as really trying to implement increased Flozin use, we're looking at trying to make sure that we're monitoring ACR. It's one of the best markers of kidney functioning, and we can see from national audits that it's not been recorded as well as we'd like. Again, I think that's partly because of inactivation of searches and prompts in our systems, but also the loss of the QOF driver. The QI project also asks us to look at other areas to consider strategies if needed for your practice. This would be a matter of looking at your data and deciding on areas that you may want to focus on, but the principal objectives here is Flozins and it is capture of ACR. We know that if we can capture the processes, identify the patients most at risk, and modify those risk factors, we will see massive reductions in cardiovascular events. If this was our friends, our family, ourselves, I think I would want to know that this is being managed as well as possible to prevent what can be very catastrophic, life-ending and life-altering conditions. I would definitely encourage that everybody have a look at the Community Health Pathways pages. You may already be familiar with these, particularly if you're in the Cardiff area and most of the South Wales health boards. These are coming to Betsy Carolda soon, and we're hoping to implement them across the country. I think these are incredibly good, with lots of links to other pages where relevant, and lots of very useful resources and advice and guidance. And I genuinely can't emphasize how impressed I am by this system, and I'm genuinely hoping that this QI project will get more people to look at this and be impressed with the work that's been done, and feel that these are genuinely supportive and useful resources to help us improve quality and actually make our day-to-day life easier and quicker. All these resources in one place, you know where to go to look for anything. Gone are the days of umpteen web page links that break, to guidance that fails and is out of date, and 4 or 5 different pathways from different teams in your area, posters on the wall, or posters on the nurse's wall, or leaflets in your desk. This is everything in one place. It's nationally agreed by the national networks. They're then localized and shared, so local GPs will work with your local consultants and specialists to make sure that these are relevant and applicable to you where you work, and will give you local resources and local details and information on how to manage patients. Now, the searches are complicated, and I appreciate not everyone's very familiar with EMIS searches, and I suspect that it'll be mostly practice managers who look at these, but I will briefly go through them. We're going to create a few videos, this first one looking at the searches, next video looking at the templates and prompts you can download and use, similar to the old EMIS prompts that match up to the searches. We're also going to have a video looking at perhaps example catch-up searches or examples on how you might want to manage workload and manage the recall for this population. There'll also be videos on how to import searches and how to import those prompts. And there will be a couple of videos on things like my merged diabetes patient plan and the frailty element of this. Now we've got a few different searches. The headline search is simply a sort of audit search, which is a combination of the various data in one place. The advantage of this search is that you can export it to Excel, and it'll give you a way of monitoring your cycles of change. So you can export this, and you could say, for example, right, this is my current population on the hypertension register. I have 91 patients with AF on my hypertension register. If I'm going to make sure that we're checking pulse for everyone who comes in, I'll want to see, do we find more AF? And we'll see this figure going up over time. The search will tell you things like who's had their blood pressure done in the past 15 months of my hypertensive register, who's had their cholesterol, their HbA1c, their kidney, who's had an ACR ever, who's had a Q-risk score, whose Q-risks are over 20, and if they're over 20, are they on the statin? And likewise for over 10, and whose blood pressure is at a target. They're quite long, but they correlate roughly to the Audit Plus searches. The only slight difference with these ones is that we count 140 over 90 as being to target, and I think there's perhaps slight variance there. And we've done a similar search for the CKD. So if we look at the CKD audit search, again, it gives you my population size, which is 7,300, numbers on the register, numbers of that register eligible for flows in, which is quite high, and I'll come back to that. Numbers currently taking a flows in. It'll also give searches along the lines of who perhaps should be coded for CKD, who's had an ACR in the past year, and that's a bit disappointingly low for me here. 150 out of 188 have had UNEs, which is reassuring. Quite a high number have had blood pressures. Less than to target according to ACR, which I guess we might want to chase. We have 65 on the register eligible for an ACE, and about half of those are currently taking an ACE. Similar for statins, 150 eligible for statin, 77 currently taking. There's also a few searches at the bottom here looking at prevalence of other conditions or comorbidity with CKD. And this is where we decided to pull in quite a lot more work on diabetes, simply because there's such a big overlap with diabetes here. Around 70% of my CKD patients have had HbA1cs over 42. So around 60% are diabetic, and about half are diabetic, and a further 25% are pre-diabetic. 25% have got cardiovascular disease already, and again around a third are either hypertensive or likely hypertensive. There's one last search at the bottom here that you can't see, which shows you your CKD patients who have never had an HbA1c, and I was slightly surprised to see we had a few of those. I think the reason it's important to highlight something like that is it's an early PDSA or an early insight into some of our data that perhaps we haven't been monitoring these areas as tightly as we can. Given that diabetes is the likeliest cause of CKD, you'd imagine that we'd have screened for HbA1c, and we've altered our processes to make sure that we do in future do that. Now, these searches allow you to just get a snapshot of where you are. When you click run on these searches, it's a useful tip is that you can choose the date that you run that search. So if you wanted to see what that data was like at the beginning of April, you choose the 1st of April and run the search then. You can then export that information into Excel and do these every month if you want to do, daily, weekly, or quarterly. It lets you then see your own data. You can get that in Audit Plus and on the Primary Care Information Portal, but seeing it yourself can be very useful if you want to play with that data, show it to your own practice, or have a more close day-to-day review of any PDSA cycles of change, so that you can actually genuinely monitor as you go, which I think is a big important element of QI. Now, I think a lot of people will simply use those searches just to see where you're up to. There are, though, the searches for each area. So, for example, in CKD, we've created searches for those on the register, those whose blood pressure isn't to target. These are the sort of populations for chasing, potentially. Those we should be considering ACE, considering finerenone referrals. One caveat here is that we should be maximizing ACE inhibitor dosage. We've had quite a few vials where we find the ACE is low, and the renal team are pointing out that we should be maximizing that first. Patients we should be considering for Flozin with the criteria. Patients we should be considering for statin, and also highlighting those who haven't had an ACR. Now, there are further folders here where I think you could, as a practice, look at things like, are you coding CKD? So are they on the CKD register? Have they got any CKD code? And we've got about 170 who aren't coded, and they have 2 EGFRs under 60. We haven't done a search including 2 ACRs over 3. This is so that we're broadly in line with the Audit Plus searches, so the numbers look broadly similar. Now, we can also look at whether they're correctly coded as G15A13. It's something the English having to do, but it's there in case people do have an interest in that area, and it can be useful for stratifying disease progression and highlighting risk. This type of search is not to say you have to go out there and code them all straight away. It's giving you a baseline. It lets you know where you're at. You may decide on different plans, or simply putting a structure in place so that when these patients are coming in, we're coding them as we go. I'll come back to that in the prompts and templates because that's got suggestions there for that. We have other searches looking at the eligibility for the medicines that we were showing. So for example, for ACE, we're looking for diabetics with ACR over 3 or diabetics with blood pressure over 130/80. That's in the pathways and the guidance. That might be a slightly different criteria to some that we've used in the past, although I think it's a very sensible criteria. We're looking for those who also have heart failure, who have ACRs over 70 and ACRs over 30 with blood pressures over 140/90. Similarly, searches for those who've had their blood pressure done, whether that's target. We have a search as well looking for patients who have had either a referral to endocrinology or renal in the past 18 months, or appear to have clinic letters from endocrinology or renal in the past 18 months. The reason for that is that quite a lot of these patients are possibly having these processes elsewhere. When you look at the video for our example on catch-up and monitoring, it's a useful search to be able to refer to there so that you can actually look to see, well, have they had these done? Can we download the processes or exclude them from recall? And then, of course, the search is looking at Flozin eligibility. So the EGFR 20 to 45, 45 to 60 with diabetes or ACR over 22.6. and you can see that we have 150 eligible patients that fall into that group. 40 of them are currently taking a Flozin, and similar searches for the statin. Now, this is the point where it's reasonable to sort of point out there's 152 potentially eligible and 39 taking. So you might say, well, there's 113 patients where we should be considering a Flozin, and you could then go back here and say, why have I only got 102? Now, we have excluded patients with type 1 diabetes. We've excluded patients with a history of DKA, and we've also excluded patients where there's a code of an adverse event with a Flozin, and we've also excluded patients who've had Flozins before and they've been stopped. The idea behind that is that we're trying to really be as effective as possible with where we're focusing our time and attention if we're trying to catch up and look at this target area. As well as the coding and eligibility searches, we've got the searches looking at perhaps who's had an ACR, who's had alcohol, smoking and weight recorded, who's had blood pressure, etc. We've done that for those on the CKD register and for those who aren't on the CKD register but potentially should be. There's a little bit of work here looking at workload. This is looking at this idea of monitoring frequency, particularly for those who might need 3 or 6 monthly monitoring. Again, these searches are perhaps more useful for when you're looking at how you might do your recall processes and your day-to-day activity, and I'll refer to that in the search when we come to look. I'll refer to that in the video when we come to look at discussing the searches we've done for catch-up and month of birth recalls. The other group of searches are the screening searches. So these are groups where we might want to look to screen. So clearly we want to make sure that we're monitoring those with CKD or likely CKD. We want to make sure that we're monitoring the diabetics, and we should be doing that as part of the 8 care processes. We should be screening the known cardiovascular group, so it's useful to look to see have they ever had their ACRs done, and how many of them have had their blood pressures and USANEs done. There's overlap between the CKD project and cardiovascular disease prevention project in that we want to screen our hypertensives for CKD, so searches for looking to see have they had ACRs, and then a whole group of other conditions. This is your structural abnormalities, your BPH, your kidney stones, your family history, they're all in there. Again, we don't have to do all this year, but I think the QI project is asking us to look at how we might consider screening, how we might consider pulling these populations in, or at least when they do come in, that we are having these things highlighted and flagged and saying, right, this person has X, Y, Z, we should consider these processes while they're here. So in summary, there is a headline audit here where you can look to see all the data in one quick summary, and then a breakdown of the areas where you might want to look as a practice to see other areas where you feel you should target, although the priority here is Flozins and ACR capture. And I think the renal team would very much want to make sure that every practice in the country is focusing on those areas, but considering the areas referred to in the QI for the ongoing sort of screening and monitoring of this population. And I'll create a further video looking at the cardiovascular and also showing why we're pulling in the diabetes into this too.